Hi, everyone. Thank you so much for attending our session, Workshop 27, CF Pulmonary Potpourri, Effects of Modulators, and more. We have a wonderful group of speakers today, and we're excited to hear from them. First, we're going to hear from Dr. Kathleen Ramos and Dr. Megan Gubacek regarding the use of Cftr, Cftr, Ivacaftor in lung transplant, and liver-lung transplant recipients. We will then hear from Dr. Raksha Jain on the effect of CFTR modulators on pregnancy. Dr. Jonathan Zuckerman will present on a prospective study of peripherally inserted catheters in CF. And then finally, Dr. D.B. Sanders will present on the STOP study assessing home versus hospital treatment of pulmonary exacerbations.
Hi, I'm Kathy Ramos from the University of Washington, and I would like to thank the workshop organizers for inviting me to present our work. Here are my disclosures. I want to talk today about the biologic plausibility of CFTR modulators after lung transplant and share some data from the CF Lung Transplant Consortium experience with Cftr, Tezacaftor, Ivacaftor, or ETI for CF lung transplant recipients. As you know, ETI does not only affect the lungs, but has the potential to improve the multi-system clinical manifestations of CF, including sinus disease, malnutrition, diabetes, and GI symptoms. The median survival after lung transplant for adults with CF is 10 years. The chronic lung allograft dysfunction, or CLAD, is the primary cause of death for people who live at least 1 year post-lung transplant. What you can see on this figure here is that by about 5.5 years, approximately 50% of patients with CF who've undergone lung transplant develop BOS or CLAD, or they've died. And so this is a really meaningful problem that is very common in CF lung transplant recipients. Causes of CLAD are multiple, including acute cellular rejection, antibody-mediated rejection, non-immune causes of epithelial injury, including acute infections from viruses, GERD, chronic sinus disease, chronic airway infection, including with Pseudomonas, air pollution, and inflammation. Studies have shown that the sinuses act as a reservoir for bacterial pathogens in CF lung transplant recipients. Surgical treatment of sinus disease has been associated with a decreased risk of pulmonary infections. For patients in whom sinus pathogens were eradicated, there was an improvement in 5-year survival and reduced rates of CLAD. CFTR modulator therapy with Ivacaftor may enhance fluoroquinolone activity against Pseudomonas. So now I want to describe our experience in CF Lung Transplant Consortium with ETI after lung transplant. We conducted an electronic health records-based cohort study at 14 CF Lung Transplant Consortium sites between October 2019 and September of 2020. And the inclusion criterion was simple. You just needed to be a CF lung transplant recipient prescribed ETI after lung transplant. And we included anyone who was prescribed ETI because we wanted to capture people for whom there were issues obtaining the medication. We collected clinical data. Pre-ETI was the closest to an ETI prescription date and within 6 months prior to the prescription. And post-ETI clinical data was the closest to 6 months after the prescription or the latest information that was available while still taking ETI. So some people had missing post-ETI data because they didn't have any new clinical data, new clinical information after starting Trikafta. And that may be because they didn't come back to clinic, and it may be because they stopped taking ETI before they had another clinic visit. Our study questions included, What are the indications for prescribing ETI after lung transplant? Is immune suppression difficult to manage because of the drug-drug interactions? And what we meant by that was it a high burden of blood tests to monitor levels? Were levels very variable or difficult to get into the therapeutic range after starting ETI? Are there observed changes in BMI, A1c, hemoglobin levels, or liver function tests? And what are the reasons for discontinuation or cessation of ETI? So here I'm going to show you the characteristics of those recipients who were prescribed ETI. So 94 patients out of 734, which is 13%, were prescribed ETI within the CF Lung Transplant Consortium. 3 out of the 14 sites had 0 patients on ETI, and the proportion of patients prescribed ETI ranged from 1% to 35% across the 11 sites. So there was a lot of heterogeneity and variability from program to program when it came to prescribing ETI after lung transplant. What you can see in this figure here is that only approximately 24% of the patients who had an ETI prescription was that prescription written by a person who only did transplant medicine, so a transplant provider. In 35% of the cases, it was a CF provider who wrote the prescription for ETI. And in 41% of the cases, it was a person who did both CF and transplant medicine, a provider who practiced in both areas. So 90 people out of the 94 prescribed actually started ETI. Among the 4 people who did not start ETI, 1 person, it was because of insurance denial. And so that really showed that 1 out of 94 people had an insurance issue, and all the other insurance companies said yes to this prescription. And that person who had the denial, it was a private insurance company. 2 of the people who didn't start ETI, it was because they didn't want to do the necessary blood work to monitor liver function tests and their immunosuppression levels during the COVID-19 pandemic. And then the 4th person actually, unfortunately, died before the ETI was delivered to her house. And so she was pretty sick with advanced CLAD. So among the 90 people who started ETI, the median age was 37 years. They were 57% women. And the time from their lung transplant to the prescription of ETI was a median of 4.8 years. We didn't have a prescription date and a start date for every person. We only had that in 71 of the patients, but we had either a prescription date or a start date for everyone. For the 71 people that we had a prescription date and a start date, the median time from prescription to starting was 20 days. And for the 40 people who stopped ETI at some point, for 39 of those, we had a stop date. And the time from starting it or being prescribed ETI to stopping was a median of 56 days. One person stopped after only 4 days, and 1 person stopped after 323 days. So the indications for ETI prescription are shown here. And we asked the research coordinators to confirm with physicians at each site whether a condition was present for each person who was prescribed ETI and whether it was a factor in the prescription of the medication. And you can see that an overwhelming majority of patients had sinus disease and diabetes and GI symptoms present, but the real driving force, the condition that was a factor for prescribing ETI was really sinus disease. GI symptoms were the second most frequent factor in prescribing ETI. Diabetes was rarely noted to be a factor for prescribing. Low BMI, clad, and considering retransplant were also sometimes factors in prescribing ETI. And it's also notable that patient preference to try it was a condition that influenced prescription pretty frequently. So here I'm showing you the clinical measures before and after ETI, and I want to just highlight three things. One is the number of measurements after ETI is really variable depending on what we're looking at, and this is influenced by the COVID-19 pandemic and the lack of in-person visits. Or the reduced number of in-person visits. And so we don't have complete data there. The lung function measurements before and after ETI did not change. There's no difference in the FEV1 or FVC percent of predicted. And there was no change in the overall median ALT or AST for the liver function test for the entire cohort, but we'll come back to that. I'm going to show you the changes in BMI, hemoglobin A1c, and hemoglobin on the next slide. I did want to note here that immunosuppression management was only challenging in 4% of cases. And for those people, they just needed more frequent blood draws than usual in order to get their immune suppression into the therapeutic range. So here I'm showing you the change in clinical outcomes for the 90 patients who started ETI. And you can see here the number who have data both before and after ETI. So 72 patients had BMI data, and though the BMI increased by 0.2 kilograms per meter squared, it was not a statistically significant increase. We only had 22 patients who had either a low BMI as a factor for prescribing ETI or a objectively low BMI, less than 18.5, prior to ETI. And there is an increase in the BMI, but it is not statistically significant. And I think we're underpowered to detect that change. For hemoglobin A1c, there was a notable decrease in hemoglobin A1c for all patients, and then also for people who had either an initial A1c greater than 6.5% or diabetes as a factor for prescribing ETI. There was also a change in hemoglobin that was noticed for people who had either mild anemia or moderate to severe anemia, and those were statistically significant. There was a reduced frequency of antibiotic use after the initiation of ETI. And what this figure shows here is the number of courses of antibiotics before ETI on the x-axis and after ETI on the y-axis. People who fall along the dotted line had no change in the number of antibiotic courses in the 6 months before ETI compared to the 6 months after ETI. People above the dotted line had an increase in antibiotic use, and there are only a handful of those. And people below the dotted line had a decrease in their antibiotic use after starting ETI. And the average number of courses of antibiotics decreased by 0.9 from 1.9 to 1.0, and that was statistically significant. So ETI was stopped pretty frequently by 40 patients, which is 44%. And most of the people, 32 out of 90, remained off of ETI for the duration of the study period. The most frequent reasons that patients stopped was because of GI symptoms, nausea, vomiting, or diarrhea, or abdominal pain. But people also experienced cough, shortness of breath occasionally, and some people stopped because they felt no benefit. So there are potential pitfalls for CFTR modulators after lung transplant, including the fact that there's no effect on CFTR in the donor lungs, presumably, drug-drug interactions, though immune suppression management was not difficult in this cohort. There's no PK data in lung transplant patients, so we don't know that people are actually at therapeutic levels of elexacaftor, tezacaftor, and ivacaftor. And there are a lot of side effects of ETI in this population. And then the cost relative to the benefit is also unclear. But in summary, nearly 100 CF lung transplant recipients have been prescribed ETI, but 1/3 stopped and remained off of ETI due to side effects or a lack of perceived benefit. For some patients, the effects were significant, with a decreased hemoglobin A1c, increased hemoglobin for those with anemia, and reduced use of antibiotics. There are multiple limitations, including the small sample size, no control group, no sinus symptoms or sinus disease metrics, and no GI symptom data. And COVID-19 definitely impacted our data collection and could especially impact antibiotic use. And further prospective study is warranted to determine whether ETI can reduce the incidence of CLAD and improve outcomes for individuals with CF and lung transplant. Thank you for attending my talk.
Hi, thank you so much. My name is Dr. Danielle Getz. I'm one of the co-moderators along with Dr. Kataki Ruel from Toronto. And I wanted to thank Dr. Ramos from the University of Washington for that presentation. And Dr. Ramos couldn't be with us today, so Dr. Joseph Paluski from the University of Pittsburgh has graciously agreed to answer questions. So thanks, Dr. Paluski. And I'm just going to see, right now I don't have any questions from the audience, so I'm just waiting. But I did want to ask regarding your presentation and your work. If you could perhaps lend some of your expertise on issues related to the access to Trikafta post-transplant, because I know in the US, the drug is more readily available than perhaps in other places.
Yeah, so that's a good question, Danielle. I was actually shocked to see how easily it was to get ETI prescribed after transplant. Essentially the same paperwork that's required for prescribing it prior to transplant is submitted with mutation data. And if the mutation data confirms eligibility, patients in our practice, and I think the data from the consortium would corroborate, were able to get the drug. I thought for sure that insurance companies would say, whoa, this person doesn't have CF in their lungs anymore. Why are you giving this drug? But it's been surprisingly easy to get. It does bring up an issue of cost benefit, and I think that's a much harder one to gauge. If one's going to seriously think about using this in a broad way, it would be really nice to have some cost benefit data. If you reduce sinus infections, you reduce lower airway infections and hospitalizations, you prevent the development of chronic lung allograft dysfunction, then maybe you can make a case that the cost benefit would be favorable.
Mm-hmm. One of the questions we got in was that the majority, were the patients prescribed this medication for sinus disease? And I wanted to see if you could comment, if it wasn't explored, is there a study planned that would look at the sinus symptoms before and after?
Yeah, I think the plan is to continue a registry analysis and perhaps add some sinus questions. We talked at length about trying to do a randomized trial, but for a number of logistical reasons, don't see that happening in the near future. There are several papers now that have been published out of the group here in combination with UNC Chapel Hill and the group at Columbia, pretty nicely demonstrating that there is benefit on sinus symptoms and the endoscopic exam in patients after Trikafta ETI compared to before. So I think we clearly know that drug helps the sinuses. Whether that would translate into a reduction in lower airway infections in transplant recipients, I think is the real unknown. The data that we collected suggesting a reduction in antibiotic utilization after would be suggestive of that, but certainly not proof of that effect.
Okay. We had a question about the dose of ETI. Was there a modified dose for these patients?
Yeah, so we don't have dosing data from each of the individual sites. We have experience in what happened to their tacrolimus levels. Essentially, my understanding from our site and others is that prescribers use the standard dose with modifications for azole utilization, and then followed immunosuppression levels at least weekly for the first several weeks after starting ETI to ensure that there weren't alterations. And a number of patients did require some adjustment in their tacrolimus levels in particular.
Great. Any thoughts on why ETI may be more poorly tolerated in post-transplant patients?
Yeah, that's a really interesting question. I think Kathy's speculation is that patients were more sensitive to side effects and were not willing to continue it because they didn't have the same subjective improvement that patients prior to transplant have generally enjoyed. So they weren't appreciating a benefit, which led them to not want to continue when were there any side effects. That's one possibility. We've seen more GI symptoms as the reason to discontinue, at least in our number, which is very limited. We have about half a dozen patients on afterwards. So I think we'll have to learn more from the consortium sites about the reasons for discontinuation.
Thank you. In terms of the chronic lung allograft dysfunction, how would we expect ETI to delay the impact or onset of that?
Yeah, so the hypothesis is that you would reduce the frequency of sinus pathogens making their way into the lung. As a result, you would reduce the bacterial burden, colonization, and/or infections in the lower airway. And we know that immune stimuli to the lower airway are probably important for lung allograft dysfunction, from community-acquired respiratory viruses and Pseudomonas and perhaps fungi, that any of those pathogens in the lower airway can be a precipitant to an immune response that then leads to chronic lung allograft dysfunction. So there are several steps in a cascade there with lots of suppositions, but certainly the most apparent one would be a reduction in the sinus microbiome abnormalities that would translate into an improved microbiome in the lower airway. The consortium plans to study the microbiome a little more carefully in transplant recipients, and we may learn something over time by a retrospective look.
Okay, and I believe you answered this to some extent, but your group had explored looking at a prospective study of sinus disease, and this person's question was, in new prescriptions for ETI, is that feasible, or like you said, would that be harder to do?
Yeah, I think we can collect better data among the consortium sites. The challenge is that most of the sites are not employing the SNOT-22 symptom survey that's most commonly used to look at sinus symptoms. So we've talked about it at the consortium, whether to have the sites start proactively doing survey before and after the start of ETI. I think that would be our best opportunity. It's going to be more difficult to justify without a prospective study doing endoscopic exams. So the studies that have been published in the pre-transplant population have done those two assessments, both symptom survey and an endoscopic exam. Dr. Zemke and our group led a two-center study that has been presented in abstract form and hopefully will be published soon, that demonstrates improvements in both symptoms and an endoscopic sinus appearance, and then potentially improvements in the microbiome. That would be the third nice endpoint to have. That work is also in progress, but if we want to get to this supposition that ETI fixes the upper airway microbiome, which helps the lower airway microbiome, which helps with chronic rejection, there's a number of data points to try and collect there.
Okay, and is sinus CT not as useful of one of those data points at this point?
Yeah, that's a good point. I think that many people have used sinus CT, and the data that I've seen where it's been done shows dramatic improvements in the sinus appearance. The amount of inspissated material is markedly reduced, just as we see in the lower airway on CT scan in pre-transplant populations where you have improvements in mucus plugging and reductions in airway wall thickness. We see the same sorts of things in the sinuses with a reduction of mucus inspissation and burden of disease.
Okay. Dr. Donaldson had asked, in addition to SNOT-22, might we want to include GI symptom scores that were validated in the Galaxy study, since this is the second highest indication for prescribing ETI in these patients?
Yeah, I think that's a good point, and it would be a good approach if we're going to continue to collect prospective data. I wish I could say we're going to get a randomized trial, but I don't see that happening. And as Scott alluded to, the GI symptoms were not delineated very carefully in the study that we've done so far. Was it nausea? Was it diarrhea? Was it constipation? We don't really know the details of that very well, but we can go back and get a look at that and talk about having a prospective analysis.
Okay. Someone asked, were there any individuals on ETI prior to transplant, and did they tolerate the ETI better than the group that started post-transplant?
Yeah, to my knowledge, none of the patients who were on it before continued afterwards, but we have to go back and look and assess more data. It's only been a subject of discussion of if you're going to start it afterwards, what would the indications be? And would you ever think about doing it routinely, meaning in the first couple of weeks after transplant, would you resume ETI? I think you can get a number of different opinions and rationales for that. I will say my own approach has been, given that we oftentimes see improvements in nutrition after transplant, to not use it right initially for malnutrition, but only in those who have refractory malnutrition. And those with sinus disease, I like to see that patients have had standard medical and surgical therapy first before we try a drug that has a high cost and potential side effects.
Right. Dr. Zuckerman had asked, do you think epithelial cell chimerism in CF patients may play a role in the beneficial effects of ETI on the lower airway infection post-transplant?
Yeah, I think that's a great question. I think the occurrence of epithelial chimerism and how much CFTR dysfunction you have in the lower airway after transplant is all speculative at this point. I don't think we really have a good idea. If the stem cell populations work the way they should, most of the lower airway epithelium should have wild type CFTR. Now, could activation of wild type CFTR under circumstances of duress, like infectious stimuli, could ETI help there and minimize infections? Maybe, but those are going to be really hard questions to answer without invasive studies where you collect bronchoscopic samples in patients before they go on ETI and afterwards.
Okay. Could there be an effect of ETI on lung infections in the native bronchi and trachea? I think you were kind of alluding to that.
Yeah, I think we don't really know yet. The surrogate for that in the study was the number of antibiotic prescriptions. But a greater prospective look would require better case report forms to allow us to define what the pathogens were, what the symptoms were, and really look in more detail at the infections. Ideally, you would know what's in the sinuses and know what's in the lower airway cultures and try and make some associations there.
Okay, one final question. Can you speculate about why they had improved hemoglobin in the ETI treated group?
Yeah, that's an odd finding, right? I have a really hard time coming up with a great explanation for that. You could hand wave and say that you have less inflammation in the sinuses and potentially in the GI tract, and that any inflammatory stimulus to reduction in hemoglobin could be mitigated by ETI. I have a hard time thinking it would be an effect on erythropoietin levels, but I guess that's also conceivable. ETI, to my knowledge, does not improve iron absorption, so shouldn't improve iron deficiency. But again, I think the mechanism there is completely unclear and a little bit surprising.
Interesting. Thank you so much, Dr. Paluski. This is a very interesting discussion. And thanks for participating today to keep us abreast of all this.
Yep, thanks to Dr. Ramos for her terrific work, and I hope she's enjoying her time away getting married.
Oh, congratulations. Thank you. So we will move on to the next talk, which is called Alexa Cftr, Tisa Cftr, Iva Cftr, Post-Solid Organ Transplant, a Transplant Center Experience, to be presented by Dr. Megan Gubacek from Baylor College of Medicine.
Hello, my name is Dr. Megan Gubacek, and I'm a third-year clinical fellow at Baylor College of Medicine and Texas Children's Hospital. On behalf of myself and my colleagues, I'd like to thank you for this opportunity to speak today to share our experience. And with that, I'll start a presentation about our project. Alexa Cftr, Tisa Cftr, Iva Cftr, Post-Solid Organ Transplant, a Transplant Center Experience. There are no relationships to disclose related to this presentation. I'll start with some background. Alexa Cftr, Tisa Cftr, Iva Cftr, or Alex Tes Iva, as I'll refer to it for the remainder of this presentation, revolutionized the care of 90% of patients with cystic fibrosis. However, the exclusion of solid organ transplant recipients in the clinical trials for these therapies have limited their use in this population, given the risk for significant drug-drug interactions, as well as unclear clinical benefit post-transplant. Extrapulmonary benefits of modulator therapies have recently been described. Also recently described is the administration of Cftr modulator therapy concurrently with immunosuppressant and antimicrobial agents in a small cohort of transplant patients. This suggests that there might be additional clinical benefits for our patients, irrespective of their transplant status, if a laboratory monitoring protocol is developed and followed. So with that in mind, our objective was to develop a laboratory monitoring protocol to facilitate safe Alex Tes Iva initiation in our post-transplant population and evaluate the post-initiation outcomes. For our methods, we performed a retrospective chart review of 9 patients with cystic fibrosis who were candidates for Alex Tes Iva post-solid organ transplant based on their genetic eligibility and their time from transplant. The data analyzed included demographic data, laboratory monitoring pre and post initiation, medication dose adjustments, adverse effects, as well as objective and subjective efficacy data. And that data will be presented in the upcoming slides. We'll start with our baseline demographics, and I'll direct your attention to the upper left-hand corner. So you can see of our 9 patients, 6 of them were male and 3 were female. Of the organs transplanted, we had 5 lung transplant and 4 liver transplants. For our Cftr mutations, all were class 2. 6 of our 9 were homozygous for F508del, and you can see the remainder of the mutations listed here. Our mean age at initiation was 16.9 plus or minus 2.3 years, with a range of 13.5 to 19.6 years. Our median BMI was 18.3 with an interquartile range of 16.7 to 25.2. We evaluated whether or not our patients had a history of CFRD, and of our patients, 66.7% did, and 33% did not. We also looked at the time to initiation from transplant, with our shortest time period being 7 months and our longest time period being 11 years. So that led to a mean of 2.97 years plus or minus 2.8. And finally, on the slide at the bottom left right-hand corner, you can see we looked at prior modulator therapy use. Of our patients, 50% had not been on prior modulators. And of those who had, the most common was Tisa Cftr, Iva Cftr, followed by Lumacaftor, Iva Cftr. We also evaluated our indications for Alex Tes Iva initiation post-transplant. And it's important to know that some of our patients had multiple indications. We've represented our liver transplant patients in light blue here and our lung transplant patients in a darker blue. And you can see that our most common indications were lung disease, sinus disease, as well as nausea and significant abdominal pain, followed by malnutrition, constipation, DIOS, and CFRD. I think something else important to note on this slide is that for our pulmonary indications, those were primarily or all liver transplant patients. And for our extrapulmonary indications, those were primarily lung transplant recipients. For our laboratory monitoring protocol, this was a center-specific protocol that was based on the following: standardized organ-specific post-transplant laboratory monitoring that was already in place at our center, the experience gleaned from other centers, the practicality of outpatient laboratory monitoring, especially within the COVID pandemic, as well as our knowledge of Alex Tes Iva pharmacokinetics. So this is represented here in the figure. And so I'd like to direct your attention to time point 1. If you can see, this is prior to initiation. And it's important to note that we did not empirically dose reduce tacrolimus, and this was based on the experience at other centers. We did, however, make adjustments to Alex-Tazaiba based on manufacturer guidelines to account for significant drug-drug interactions if they existed. Our baseline tacrolimus trough and liver function tests were obtained at this time point. At 7 days and 14 days post-initiation, we have re-obtained our tacrolimus trough and our liver function tests. And as long as stable at 28 days to 1 year post-initiation, we obtained tacrolimus trough monthly and LFTs every 3 months, at least every 3 months in our lung transplant population. In our liver transplant population, we obtained tacrolimus trough and liver function tests monthly. We also utilized a Cftr modulator monitoring protocol. And this, again, was a center-specific protocol that was based on the manufacturer's package insert with adaptations for pharmacokinetics, outpatient monitoring practicality, and our own center's experience in using these medications in non-transplant patients. And this is really developed to guide long-term laboratory monitoring as well as dose adjustments if needed on Cftr modulator therapy. You can see this represented here in the table, and in the leftmost column, you can see the LFT result, followed by the dosing and monitoring recommendations if dose adjustments were required. For our outcome measures, we looked at 2 arms, safety and efficacy. With regards to safety, we evaluated immunosuppression, our allograft function, and adverse effects. When referring to immunosuppression, we're specifically talking about tacrolimus dose adjustments and whether they were required or whether it was feasible to maintain our goal ranges for immunosuppression throughout the therapy. So on the left side of the figure here, you can see our lung transplant patients are on the top and liver on the bottom. In this first column, this is representative of the dose change and whether it was required at the first check post-initiation of therapy. The second column is a summary of our percentage dose changes that were required. And the last column is whether or not a second dose change was required. I'd like to direct your attention back to this second column here, where you can see that for most of our patients, we required a decrease in therapy. However, we did have 2 patients that required an increase. Those were confounded by a change in oral intake for patient 1, and then by voriconazole being discontinued for patient 7. In summary, 8 of our 9 patients required a dose adjustment at the first modulator initiation trough. 1 to 2 dose adjustments were required to obtain organ-specific immunosuppression within the goal range, and we were able to maintain this throughout therapy without much difficulty. A 20 to 25% dose adjustment was the most common, though this is really based on the dosage form that the patient currently had in an effort to use their existing medication. We looked at lung allograft via the FEV1. And so you can see on the y-axis, the FEV1% predicted, and on the bottom, we have, on the x-axis, we have a pre and a post time point. You can see that this FEV1 was obtained at a mean length of time of 2.2 months post-initiation. And what's notable here is that our FEV1 was maintained or increased post-initiation for most patients. Patient 9 is our most recent initiation, and we had a change in the FEV1 from 97 to 95% predicted. So this will be an ongoing monitoring to understand if this will be a trend for that patient. We also looked at adverse effects. So 4 of our 9 patients had an increase in liver enzymes or bilirubin while on Alex-Tazaiba therapy. 2 lung patients had elevated bilirubin, though no dose adjustments were required based on our protocol. 2 liver patients had elevated transaminases. This was deemed to be secondary to acute cellular rejection. And while this was not thought to solely be due to Alex-Tazaiba therapy and more related to non-adherence in general, this therapy was held during the treatment for acute cellular rejection and then resumed at a later date. With regards to ongoing adverse effects, 1 patient did develop a rash and a headache for 48 hours post-initiation, but this resolved without any intervention and no dose adjustments or discontinuation of therapy was required. We also had 1 patient that had worsening subjective abdominal pain from their baseline and had minimal perceived efficacy while on the therapy. And ultimately, this therapy was discontinued in this patient. For our efficacy data points, we analyzed the following: the FEV1 for our liver transplant patients, the BMI, hemoglobin A1c, markers of sinus disease, and subjective efficacy data points. Looking at our FEV1 and liver transplant again, on the y-axis, we have our FEV1 percent predicted, and then we have our pre and post time point again. This was a little bit lengthier. So our FEV1 was obtained at a mean length of time of 4.9 months post-initiation as compared to 2.2 for our lung transplant patients. But what's most notable here you can see is that all of our patients had a significant increase in their FEV1 post-initiation, with a mean percent change in FEV1 for our liver patients of 23.4%. So really significant increase for our patients. We also looked at BMI. We noted that 66.7% of our patients did have an increase in their BMI on Alextez therapy, though this wasn't as significant as we initially had thought in our preliminary data. We also note that of our patients, 3 actually had a decline in their BMI. For one patient, this was related to post or peri-procedural oral intake decrease. However, it's unclear why the other patients had a decrease. And this is something we're going to be continually monitoring and evaluating to see whether this is going to be a trend for our patients or if we'll start seeing an uptrend even for those patients that had an initial decline. For additional outcomes, we evaluated the hemoglobin A1c, and we noted that of our patients, 2 of 6 had a decrease in hemoglobin A1c, and 4 of 6 had an increase in their hemoglobin A1c. With regards to sinus disease, we looked at a subjective reduction in sinus rinses and noted that in one of our 4 patients with sinus disease as a primary indication, there was a reduction in the subjective use of sinus rinse. Finally, probably most importantly, we looked at our subjective efficacy data. And from one of our transplant coordinators, for months, she was having nausea and could barely eat. We were trying different medications all the time. Things would maybe work for a few weeks, and then I would get a call or message from mom that the nausea was back. I think at some point she said she felt better pre-transplant just because of how miserable she was with the stomach issues. Finally, we tried Alextez IVA, and mom says her old self is back, and we couldn't be happier. From one of our transplant physicians, the cough is improved, it's more dry. Since starting Alextez IVA, she wakes up with better energy and in a better mood. Her saturations have been in the upper 90s since starting on Alextez IVA, and her cough is much improved. And finally, from one of our liver transplant physicians, he is now on Alextez IVA and reports that he breathes much easier. So overall, this was an important data point for us, and happy to report those results, even though they are subjective. So a study has limitations. This was a retrospective study with a small sample size and a relatively short length of study. Some data points are subjective, and there are more objective measures we could obtain, specifically talking about a respiratory symptom score or measures of sinus disease. So that will be kind of ongoing. And then we had difficulties with obtaining sustainable data based on the practicality of outpatient monitoring, specifically our FEV1 time points, and continuing up with that laboratory monitoring was difficult. But in conclusion, with dosing interventions guided by protocolized laboratory monitoring, immunosuppression and modulator therapies were continued in a safe manner. Alextez IVA initiation in our post-transplant patients resulted in improved pulmonary and extrapulmonary effects, as well as improved quality of life by subjective measures and minimal side effects in most patients at our center. However, this was, again, a short time point, and for some of our patients, our therapy have been on therapy for 3 months and as long as 22 months. And so further investigation is necessary to determine if this remains a positive therapeutic intervention for our patients. So our next steps are to reassess our current efficacy data points and to look at assessing other data points like cost effectiveness, whether or not this reduces hospitalizations or therapy use. For sinus disease, whether there's an actual reduction in sinus surgeries or a change in imaging findings, thinking about more objective quality of life measures. And so those are future directions we'd like to take this project in. I'd like to acknowledge my collaborators here and thank you again for the opportunity to speak today. I'm happy to take any questions at any time, and I want to thank you again.
Thanks so much, Dr. Gubicek, for your presentation and for being here today to answer questions. So we just had a few questions about how you think in post-liver transplant patients specifically, will ETI lead to more biopsies, or is there a way we can differentiate the transaminitis in post-liver transplant from the rejection phenomenon?
Yeah, I think that's difficult to know at this time, especially just given kind of our small sample size and cohort here. We noted, though, that after that initial episode of acute cellular rejection for those patients were restarted on electrolyte therapy, and since really haven't had any changes in their liver transaminases since that time. And so we've been able to continue it without much difficulty, even in those patients who previously had rejection. And so I think it's kind of a little bit early to tell, and I think that's an interesting thing to potentially continue to follow up on long term.
Okay, great. And given that patients often gain weight post-ETI initiation and patients post-transplant gain weight as well, are there any concerns for metabolic syndrome in these patients or excessive weight gain?
Well, as you saw in our data, we actually had 3 patients that actually lost weight. And so we didn't actually find our BMI data was as robust as we thought it originally would be in terms of the gain. And we also had many of our patients that were, like I said, somewhere between 7 months and 11 years out from transplant. And so that also obviously affects our data a little bit. And as we noted too, that we had some patients that actually previously had CFRD who had an increase in their hemoglobin A1c. And so it's an interesting thing to evaluate, though we haven't really seen in our specific cohort that there's been a really robust increase in their BMI so far.
And are you planning to extend your research to other centers, or how will you pursue kind of doing this research as maybe as part of a registry look?
I think at this time, obviously, we have a small sample size here in pediatric center, and we have been working again with our liver center here as well to kind of obtain this data, and certainly reaching out to other centers to extend this data would help us in the pediatric population significantly. Right now, we hadn't had plans to do that specifically, but definitely are interested in considering that as a possibility moving forward.
Can we say in terms of, again, access and advocacy issues, should we be prioritizing ETI and liver transplant recipients over lung transplant, given the potential benefit to the lungs in the long run?
Yeah, that would be a difficult question to answer. And I think certainly if you're speaking for measures of lung disease, knowing kind of the indications that we had for both our liver and lung transplant patients, I think it depends on a lot of factors, right? So we're not just talking about lung disease in these patients. There's other indicators, GI illness, sinus disease that we're talking about, malnutrition. And so not sure how to kind of quantify how we would prioritize those patients, but certainly in terms of the overall indications, including lung disease, liver patients could theoretically have more indications for this therapy.
And also someone had asked about the impact. There was some effect on hemoglobin A1c in this group. So if people have CF-related diabetes, should ETI be an indication in the transplant recipients?
Yeah, I think, again, we've seen kind of when looking historically at the data that people had significant improvements in their hemoglobin A1c, and we didn't necessarily see that in our center. So I'd like to think that. However, 4 of our 6 patients actually had an increase. So this is a unclear reason why, too. We don't really have a specific understanding of why we had an increase in our patients, and whether or not that is that they were feeling better, they have less sinus disease, they're eating better. We don't entirely know why that increase was. And so kind of long term, it'll be interesting to see if we actually see what other centers have experienced with the reduction in the hemoglobin A1c and using that as an indication for potentially initiating this in those patients. But kind of with our limited data, we actually didn't see, that significant decrease in all the patients as we expected we would.
Okay. And do you have plans, or your group, to look at impact of ETI on chronic lung allograft dysfunction?
Yeah, and again, I think, we have most of our patients were somewhere between 7 months and 11 years out, and they're getting routine biopsies. We're not just looking at things like FEV1, although we did see a significant increase in that. So we are also doing transbronchial biopsies on these patients routinely as part of their routine transplant monitoring. And so obviously that's going to be something that we're monitoring long term. I think kind of the question we're most kind of arriving to at this point is, having some patients on it for 2 years, has it really made much of a difference in terms of the cost effectiveness in continuing this therapy? And so probably need more data long term, with in addition with biopsies and other markers to kind of evaluate the impact on rejection long-term, but or allograft dysfunction. But at this point, we have not seen that in our patients.
Okay, thank you. And then is there a group of patients post multi-organ transplant who can become part of this cohort, such as lung, liver, lung, kidney, etc.?
I'm not aware of any of those patients, but I think a question for our transplant directors. We have talked a little bit about how historically multi-organ transplant patients, that's something that if we can improve other markers of health for these patients, we could see outcomes, comparable outcomes or improved outcomes for a lot of efficacy data for these patients. But at this point, I'm not aware of any patients in our center, but that would be a different question for someone maybe who knows a little bit more than I do.
Well, your work has been impressive. I think we're doing great, and we appreciate your presentation today. Good luck in your future work.
Thank you guys for having me. I appreciate it.
Thank you.
Good afternoon. I'd like to start by thanking the session chairs for the invitation to present today. The title of my talk is The Effect of Pregnancy on Lung Function and the Impact of CFTR Modulators. My name is Raksha Jain. I'm an adult pulmonologist at the University of Texas Southwestern Medical Center in Dallas, Texas, and I'll be presenting these results on behalf of my co-PI, Dr. Jennifer Taylor-Kauser. We'd also like to thank our co-investigators for their hard work on this project. I have no disclosures to report related to this presentation. I do receive funding from the CF Foundation related to committee participation unrelated to this study, and consulting fees from Vertex Pharmaceuticals, Gilead Sciences, and Boehringer Ingelheim for work unrelated to this presentation. So to start, as many know, pregnancies in women with cystic fibrosis are increasing. You can see from the CF Foundation annual data report that pregnancies have been increasing over time. In fact, we anticipate that in 2020, we will see over 600 pregnancies reported in the United States, more than we've ever seen before. So questions regarding the impact of pregnancy on maternal health are becoming increasingly important. To investigate this, investigators have used a number of data sets out there to determine what the effect of pregnancy is on the health of a mother with cystic fibrosis. Goss et al. Reported in 2003 using the CF Foundation Patient Registry an analysis of survival and looked at those women who'd experienced a pregnancy versus those who'd never experienced pregnancy, and found that there was no survival disadvantage in those women who'd been pregnant. And in fact, they may have had an increased survival relative to women who'd never been pregnant. It's important to acknowledge, however, that these women who had experienced pregnancy overall had a better baseline health. In another study reported by Cftr and colleagues in 2013, using the epidemiologic study of CF, they found that amongst pregnant women, which were 119 in their analysis, they had more illness-related visits, more pulmonary exacerbations, and reported a lower quality of life score. However, they did not find that these women had an accelerated progression of disease, increased use of therapies, or increased mortality. Others have looked at outcomes of pregnant women with CF versus outcomes of pregnancy in women without CF using very large data sets. In 2017, Jalen et al. Used a California database to evaluate 77 mothers with CF versus over 2 million without CF, and found that in those with cystic fibrosis, there was a higher likelihood of having gestational diabetes and higher rates of C-sections. They also found that in neonates born to those with cystic fibrosis, there was a higher likelihood of having a preterm delivery of less than 37 weeks and having congenital anomalies. In another database analysis by Patel and colleagues reported in 2015, they found that in over 1,000 mothers with cystic fibrosis versus 12 million without, that the mothers with CF did have a potential increased risk of death, increased risk of pneumonia, preterm labor, and gestational diabetes. So it's very important for us to take a deeper dive into this as more and more women with cystic fibrosis are planning pregnancy. The other question that stands out about pregnancy is the impact on Cftr modulators. As we know, Cftr modulators are now available for approximately 90% of the population, and it's very important to understand the impact these modulators can have on both the mother and the infant. To start to take a look at this question, investigators have surveyed sites that have had women at their centers experience pregnancies. In an international survey published by Nash and colleagues in 2020, they found that amongst 74 pregnancies reported, 31 of these women were on ivacaftor, 26 on Lumivy, and 7 on Tezivy, that in 44 of these pregnancies, women had some type of modulator exposure. Amongst them, there was 2 maternal complications that were deemed related to Cftr modulator exposure. 9 of these women who stopped modulator therapy at some point in their pregnancy had a decline in their health. And there was no modulator-associated complications in the infants. When looking at another study published by Jennifer Taylor-Kauser and colleagues in 2021, focused on elexacaftor, tezacaftor, ivacaftor, and again, surveying sites, they found that in 45 pregnancies where there was ETI exposure, that there was 1 maternal complication deemed related to ETI, 2 complications that were deemed unknown in their relatedness to ETI, and 3 infant complications deemed unknown in relatedness to ETI, 2 infant complications deemed unrelated to ETI. So overall, I'd interpret these results as promising and that we do not yet see a concerning signal for modulator use in infants born to mothers who use them with cystic fibrosis. So to further understand this question, the objective of our study was to determine the effect of pregnancy on maternal health outcomes and whether they differed by modulator use. We had 11 participating adult care centers from across the United States involved in this study. They helped collect de-identified retrospective data on pregnancies of women at their care centers that had a pregnancy between January of 2010 and June of 2021, and collected data from their electronic medical record with permission of their local IRB and entered this de-identified data into our REDCap database. We collected data 1 year prior to pregnancy, throughout the pregnancy, and 1 year post-pregnancy. Our primary outcome was lung function. We use linear regression for evaluation of FEV1 and BMI, body mass index, and we use Poisson regression to evaluate number of pulmonary exacerbations pre and post-pregnancy. We adjusted the analysis for potential confounding effects, including the age at conception, race, pre-pregnancy lung function, and whether the pregnancy was planned versus unplanned. Taking a look at the demographics in this study, we had 350 total pregnancies entered into our database in 271 different individuals. We did, for this analysis, exclude 112 of these that lacked FEV1 data in the 1 year prior or 1 year post-pregnancy, and 8 that lacked data on whether there was any modulator use during pregnancy. So overall, we ended up with 180 women, 94% of those which were Caucasian, and of which each woman experienced a mean of 1.27 pregnancies. So a total of 228 pregnancies. Amongst these 228, 151 of those had no modulator use at any point during pregnancy, 22 which used a non-highly effective modulator therapy at some point, and 55 used a highly effective modulator such as ivacaftor or elexacaftor, tezacaftor, ivacaftor at some point during the pregnancy. The mean age of conception in our total cohort was 28.8, and the average FEV1 pre-pregnancy in our total cohort was 73.7. So looking at our first variable, which was change in percent predicted FEV1 pre and post-pregnancy, I'm just showing our adjusted analysis, and you'll see in this graph that the black dotted line were those that used no modulators at any point in their pregnancy. The solid black line are those who used a non-highly effective modulator at some point, and the blue line, those that used a highly effective modulator at some point. So looking at the adjusted mean difference pre to post-pregnancy. We saw for those with no modulator use, there was a decline in lung function of 2.4, which was statistically different. There was a decline for those that used a non-highly effective modulator therapy of 2, which was not significantly different. And for those that used a highly effective modulator therapy, there was actually an increase of 2.14, which was statistically different. And importantly, there was a statistical difference in the interaction, meaning that the change in FEV1 pre versus post-pregnancy significantly differed by modulator use. When you further look into pulmonary exacerbations, you see that when looking at the no modulator group, there was a very slight decline in pulmonary exacerbations, which was not significantly different. In the non-highly effective modulator group, there was a 21% decline in pulmonary exacerbations, again, not significantly different. And for the highly effective modulator group, there was a 38% reduction in pulmonary exacerbations, which was significantly different. The interaction here, meaning the difference by modulator use in pulmonary exacerbations, was not significant. And finally, looking at the adjusted change in BMI pre and post-pregnancy, we found for those that use no modulators, there was not a notable change in BMI pre to post-pregnancy. And those that used a non-highly effective modulator therapy, there was an increase of 0.5 that was not quite statistically different. And in those that used a highly effective modulator therapy, there was an increase of 1.64, statistically different. And here again, the adjusted change in BMI by modulator group did have a significant difference. And finally, just to summarize some of the infant outcomes collected, this is looking at the total number of pregnancies in our data set. That was 361. We found that of those, 45 or 12% experienced miscarriages or spontaneous abortions, 15 or 4.2% induced abortions, and 1 or 0.3% is stillbirth. So there was a total of 260 live births in our data set. Of these live births, when you look at the mode of delivery, 161 of those, or 61%, were delivered vaginally, 90 or 34% were delivered via C-section, 7 via forceps, and 6 vacuum assistance. There were 83 of these, or 31%, that experienced a preterm birth, meaning they were born before 37 weeks, and 45 or 17% that were born of low birth weight, less than 5.5 pounds. And looking at NICU stays, 66 of these did end up going to the NICU for some amount of time, which is 25%, with an average NICU stay of 29 days. We did have 36 of the pregnancies in which there was no infant data recorded. So just to summarize our findings thus far, we found that in those that used no type of highly effective modulator therapy, there was a decline in percent predicted FEV1 after pregnancy, with a minimal change in BMI and pulmonary exacerbations. In those who did use a highly effective modulator therapy at some point during pregnancy, we see a stabilization in their lung function post-pregnancy, if not a potential increase, though further work needs to be done to evaluate this, as well as an increase in BMI and a decrease in pulmonary exacerbations. We cannot yet make any conclusions about the impact on infant outcomes. So it's important to recognize that we had some limitations to this study. First off, it was a retrospective data collection. The timing of highly effective modulator release, particularly ETI, in relationship to our data collected, needs to be further evaluated. We recognize that our medication use is only as reliable as what was documented in the electronic medical record for these patients. And there may have been missing data. I already acknowledged the missing data we had in lung function, as well as missing data that may have occurred in pregnancies overall if, for example, a miscarriage was not reported to the care center. We have a number of ongoing queries we're doing to clean this data set, so these results are only preliminary. In addition, we plan to do some further analysis to adjust for variables such as CF-related diabetes and socioeconomic factors. We have some additional work ahead of us. We do plan to link our data set to the CF Foundation Patient Registry in order to analyze some longer-term outcomes. We'd also like to look at outcomes stratified by severity of mother's lung function at baseline. We hope to take a further deeper dive into modulator use by trimester and even the impact of modulator withdrawal on maternal health. We'd like to look at the outcomes of women who had a planned versus unplanned pregnancy and those who had a single versus multiple pregnancies. And further, we'd like to see if we can understand more about risk factors associated with infant outcomes. And I'd finally like to mention that there is an ongoing prospective observational study of pregnancy and cystic fibrosis that's really going to allow for more granular data collection. This is called the Mayflowers study. Enrollment has begun, and it's being supported by the CF Foundation and the TDN. Thank you so much for your attention. I'd like to end by acknowledging the CF Foundation for funding this work through a clinical research award as well as through a StatNet award. I'd like to thank my co-PI on this study, Dr. Jennifer Taylor-Kauser, the UT Southwestern study team, Ashley Keller, Minjae Lee, Laura Henry, and Terry Visnick-Chang. And I'd also like to thank the many participating site PIs and their study teams for the hard work they put into in getting this data entered. Thank you very much for your attention.
Thank you so much, Dr. Jane. It's so uplifting to hear this data presented. Something about people having babies that they weren't able to have before is really great. So thank you for your work. We have a lot of questions already. So people are asking about the effect of modulators on pregnancy. There seems to be a big difference in the number of exacerbations, but the post-pregnancy FEV1 may just be a few percentage points. Can you comment on this larger effect on the exacerbations?
Yeah, I should definitely acknowledge there are some limitations in the study that we need to tease out. And some of this is the timing of a lot of it, in that, one, based on the timing ETI was released, and two, the timing of the pandemic very much could have affected our exacerbation rates and our FEV1. Mm-hmm. So we really got, the last of this data in the end of August. So we have a lot of looking at the details of that to evaluate, but I would guess the combination of that timing of both of those events really impacted these results. So that's why I think in my conclusions, I really said that I think we see an improvement overall or a stabilization in health. I'm hesitant to say yet that we have an improvement until we really look further into the timing of all of this.
That makes sense. And someone asked, I'm not sure, because you had mentioned that looking at the results in infants, we need to do more work, but someone had asked about the impact of ETI and the lung function of the neonate. How can we measure this? Is there a thing as super Cftr function? As a pediatric pulmonologist, I'm not sure that it would cause a super function, but I don't know what you think.
I wonder if the question is more about if a baby was born with CF.
Yes, yeah.
I think that might be what they're asking. So we do not know of any of those babies in our data set yet that we're aware of that were born with CF. Now, I have to acknowledge that in our study, all the sites had IRB approval to look into the mother's chart. So any infant data we had was infant data collected from the mother's chart. So we don't have a lot of granular data about the babies. That will be the kind of data that we're able to collect in this prospective observational Mayflower study that's about to begin. So we are not aware that any of these babies had CF, but I think that's a fascinating question that everyone is interested in, is if a mother with CF is taking ETI and has a child by chance that ends up born with CF, what's the impact going to be on that infant? But I would definitely say in our collection of data, we don't know that. And I think it'll be a matter of by chance, if that happens in the Mayflower study, then maybe we'll get a sense of that.
Okay. And looking at the data for the infants, were the incidence of spontaneous abortions similar to the normal population?
Yeah, that's a great question. So actually, it was fairly similar. I think we found a rate that was about 12% or so. Mm-hmm. And I think if you look at spontaneous abortions or miscarriages in the general population in the first trimester, it tends to be about 15% as well. So it was fairly similar, though we have not yet broken down how many of those occurred in first trimester versus second trimester, et cetera. But it did fall in similar lines. So that was good news that we're not seeing some increased rate of that with use of modulators or in CF women in general.
Okay, great. And then the same thing, and I'm sure the Mayflower study will look more into this too, but the incidence of preterm births, was that on par for CF moms that, and the general population? It was 31% were born preterm.
Yeah, so actually that is higher than the general population. So in the general population, I believe the incidence of preterm births is about 10%, depending on how you look at it. So we're definitely seeing a higher rate of preterm birth. That is something that has been reported in some of those previous studies that I outlined at the beginning of my talk. We have not yet broken that down at all into those babies that were born to a mother that used modulator therapy or did not use modulator therapy, but that is a known phenomenon of women with CF, and that did, repeat in our data set as well.
Okay, and someone from the audience asked if preterm births correlated with the women's nutritional status pre or during pregnancy.
Yeah, that's a great question. And I think a lot of these infant outcomes, one, we have to acknowledge that we can only really provide the statistic. I don't think we can make big conclusions about this yet, but we have not looked at that. We're very curious to look at a number of different factors from mothers' baseline BMI, baseline lung function, et cetera, on the outcomes of the infants, but we have not yet done that. We're hoping that by the time we get the data cleaned up and ready for publication, that we can put some of that in our publication.
And someone else asked about maternal weight gain and the low birth weight babies. So I'm sure that the data you collect would also include that.
Yes, it will. And, I also have to say that when it came to the infant outcomes that I reported in this talk, I used the entire population. And in the actual analysis of the mother's outcomes, we had to exclude over 100 women that did not have any data pre or post their pregnancy. And I think that's something really to highlight is that, of our data set that had 370 plus pregnancies, we actually had to exclude about 100 of them that lacked any FEV1 data either pre or post the pregnancy. So some of the data may not match because I'm reporting more infant outcomes than actually what we looked at in terms of maternal effects, but we do plan to really take as much of a dive into this as we can with limited conclusions, knowing that we have a small data set and that we're also using data from the mother's chart that may have limited information on the baby.
In reference to that, is outside of trying to get everyone to kind of participate in the Mayflowers study, is there an ideal interaction with the OBGYNs or something that the CF Center should pursue, or that would help that?
That's a great question. And actually, I listened to a terrific talk yesterday by a woman from Ohio that presented their center's new plans they have made on really creating a multidisciplinary team to take care of women who become pregnant. And that multidisciplinary team included the CF team, it included an endocrinologist, it included the maternal fetal medicine doctors, it included the neonatologist. And I really do think that, that is a really important point, that as many of us are seeing an increase in these pregnancies, and I think as now the 2020 registry data is released and we have over 600 pregnancies reported in 2020, I would not be surprised if in 2021 we see even more than that. So I think all of our sites are going to be seeing more pregnancies, or at least the adult centers. So we really do have to reach out to our colleagues in maternal fetal medicine and in endocrinology to really ensure that we're taking the best care of these women we can. And, I think it was so rare that these relationships were not established before, but I think this is really the time to do that now.
Sure. And Dr. Sawicki had asked how you plan to capture infant data and what type of data will be captured in Mayflowers, if you're able to comment.
Yeah, so that's a great question. So we will be getting the permission of mothers in the Mayflower study to collect infant data for actually 2 years after the baby is born. And we are going to be getting directly pediatricians' records from that. We are not going to be collecting data as part of the study. It's all going to be whatever that pediatrician chooses to do. We're going to collect that data. So ideally, that will include newborn screening data. That actually is also going to include developmental milestones on that baby for 2 years after the baby's born. It's going to include liver testing. If the pediatrician does liver testing, it'll include ideally ophthalmologic exams on mothers who take Trikafta if that is done. But these are all things we're educating people on, that we recommend these things are done. Whether or not they occur, we'll see. But if it does occur, we'll be able to capture that data from the pediatric records.
Okay, thank you so much. So we've reached our time for questions, but thanks so much, Dr. Jane, for your presentation.
Thank you.
And our next presentation will be results of a prospective multi-center study of peripherally inserted catheters in patients with CF from Dr. Jonathan Zuckerman.
Hello, I'm Jonathan Zuckerman, and I will be presenting data on behalf of the PIC-CF investigators. We thank the organizers of this workshop for inviting us to show you our results of this multi-center prospective study of pediatric and adult people with CF who underwent placement of PICs over a 3-year period. I have no disclosures related to this project. Well, if you've treated patients with CF for pulmonary exacerbations, chances are that at some point you've run into a complication of a PIC like local phlebitis, venous thrombosis, or more seriously, a catheter-related bloodstream infection or venous stenosis. These radiographs from 2 patients illustrate stenosis of the superior vena cava related to PICs. In fact, one of these patients was presented at the Physicians' Grand Rounds at a previous North American CF conference, and Mike Boyle was the discussant. Previous studies of PIC complications in CF have primarily been retrospective in design and conducted at single centers. Mermis and colleagues at the University of Kansas reported on a single center QI project that found much more frequent venous thrombosis in size 5 and 6 catheters compared to size 4 catheters. And subsequently, their program increased the use of 4 French catheters. Their incidence of thrombosis was 8.4 to 14.2% in 5 and 6 French catheters. Likewise, in a multi-center retrospective study by May et al. From the Northern New England CF Consortium, they found that patients who received a 5 French catheter had more than a 2-fold increased risk in thrombosis compared to those who received a 4 French catheter. Importantly, the retrospective nature of these studies only identified complications that were documented in the medical record. Furthermore, a survey conducted by May revealed that considerable variation in line management practices among CF programs. So in light of the potential for serious complications of PICs, indications of variation in line insertion and management practices, and the lack of prospective data on the use of these devices, which by the way are not tracked in the CF patient registry, we set out to evaluate associations between patient level factors, catheter level factors, and catheter management factors, and the risk of subsequent PIC complications in a multi-center observational study. Our primary endpoint was the occurrence of symptomatic venous thrombosis. I'll give further details of our study definition in an upcoming slide. As secondary endpoints, we also assessed for other complications of these catheters, such as catheter-associated bloodstream infection, pain, catheter malfunction, difficult line placement, and phlebitis. In today's presentation, I will focus for the most part on thrombotic complications. Here we see a schematic of our study design where potential participants are screened for eligibility. Following consent, baseline demographics and relevant medical history was obtained. Details of the catheter insertion were carefully recorded in a REDCap registry, and photographs were taken of the insertion site. Being an observational study, we did not dictate to the treatment team any aspect of catheter selection, placement, management, or workup of thrombosis or removal of the catheter. However, per protocol, we did obtain blood work, including a CRP and D-dimer that was obtained at the time of the catheter insertion and on the date of removal, when feasible. Participants were followed every 2 to 4 days while the catheter was in place, either in the hospital or in the home setting, to check for complications. Those who were in the hospital had arm circumference measured as part of this assessment. Now here we see a representative photo from one of the study participants who had a PIC placed, and a cartoon of the arm diameter measurement. We were most interested in assessing for symptomatic venous thrombosis, so we therefore utilized a validated tool called the constant score, in which a score of greater than or equal to 2 has a reported sensitivity of 86% for venous thrombosis. Here we see the curves for screening and enrollment in PICC-CF. When we designed the study, we initially set a target of 1,000 lines to have adequate power, assuming a complication rate of 6%. However, two important events affected enrollment. First, with the rollout of elexacaftor, tezacaftor, ivacaftor in late 2019, and followed by the COVID-19 pandemic, we saw both of these dramatically depress the frequency of pulmonary exacerbations. In addition, some of our study sites put a hold on clinical research during the pandemic, and we see that further limited enrollment, which is shown by the green line. Interestingly, 36% of our patients who had lines placed were on CFTR modulators during the study, with a higher percentage of those being seen in adults. Now, this complex slide shows a summary table of our study population and shows that it's generally reflective of the CF population in many respects, but it should be noted that lung function is well preserved in many of our patients, likely due to the fact that many patients with more severe disease are treated with totally implanted vascular access devices like Metaports. Now, let's focus on a number of factors that are more specific to our study. We see that the average number of PICCs placed in our adults was 5 and 3 in the children. 6 to 7% had a prior history of venous thrombosis, and 85% of our patients had no prior history of difficult PICC placement. On the other hand, 4.5% of children and 7.6% of adults had a history of previous difficulty with wire passage during PICC placement. History of thrombophilia was rare. One of the surprises of our study was the number of PICCs that the patients had experienced over the years. Here we see that quite a few of our patients had undergone more than 10 PICCs placed, with the range extending up over 30. A fascinating part of the study was to learn about the range of variation in practice over many aspects of line management. For instance, shown in panel A, we see that many of our study centers rarely use prophylactic anticoagulation after line placement. However, in one adult program, we see that more than 50% of patients received prophylactic anticoagulation, and in one pediatric program, all the patients received prophylaxis. On the flip side, most of our CF centers did use the PICCs for blood draws. However, there were some outliers where the blood draws were not used, PICCs were not used for this purpose. On the other hand, the vast majority of PICCs were placed under ultrasound guidance, and this was associated with fewer needle sticks. In fact, 86% of our PICCs placed during the study were inserted with a single needle stick. While at first it may seem like there was considerable variation in catheter size in our study population, when we look at this in tabular form, we see that in adults, 84% had smaller than a 5 French PICC catheter placed, and nearly 98% of pediatric patients had a smaller than 5 French catheter placed. We have time limitations for today's study, but I do want to give brief coverage to an analytic technique that we hope will prove very useful as we dig through details of catheter selection and management. The technique, called temporal sequence analysis, allows us to visualize patterns of care and outcomes over our entire study population. Let me walk you through an example of how we could use this technique. In this plot, we see 375 catheters plotted on this single image, and each catheter is shown as a single horizontal line. The green lines show the experience in the inpatient setting, and the purple lines show the catheters when used in the outpatient setting. And the central gray bar shows the each center ranked by the number of catheters placed, going from top to bottom. We see striking differences between centers in terms of their use of inpatient versus outpatient care. Not only that, if we look more closely, we see that there are different patterns of line management, including use of blood draws, where here we see in this group of patients, no blood draws being done at this particular center, no blood draws done through the PICC catheter, and we also see variations in use of heparin. We plan to do further analyses of catheter-related pain, skin irritation, and catheter malfunction, sorting by other characteristics like catheter size and flushing practices. Our collective impression going into the study was that catheter-related bloodstream infection is rare in CF patients, and this was confirmed over 4,705 PICC days of observation, despite considerable variation in line management practices. In terms of thrombotic complications, we found a lower frequency than was reported in the previously cited retrospective studies. For example, in the Murmas study, they reported 2.3 episodes of thrombosis per 1,000 PICC days following their QI intervention. However, their definition of thrombosis did include DVTs along with superficial venous thrombosis. So by comparison, we're about half that frequency. This next table shows each instance of a catheter where there was a constant score of 2 or greater. In 2 of those episodes, we documented deep venous thrombosis by ultrasound, and in 3 cases, there was superficial thrombosis. In 2 other cases, ultrasound revealed no evidence of thrombosis, and in 3 cases, no ultrasound was performed, but these patients all did well with clinical management. Now, I want to quickly walk through this slide. Feel free to review it again later if you want to look at a recording of this session. But in our study, we found that the average vessel size accessed for PICCs in our adult patients was 4.5 millimeters. Using the Hagen-Poiseuille equation, which describes the flow of liquids in a cylindrical pipe, we see that resistance to flow is inversely proportional to the radius to the 4th power of the cylinder. So in a vessel of 4.5 millimeters, going from a 4 French catheter to a 6 French catheter is estimated to increase resistance to blood flow by nearly 3-fold. Think of that when selecting your next PICC. In conclusion, we have found in a large multi-center prospective study comprising 4,705 catheter days of observation that there was no instance of bloodstream infection, and there were only rare instances of venous thrombosis. These were found despite considerable variation in catheter management practices. However, there appears to have been an evolution in approach to catheter selection and insertion over the last 2 decades. In our study, we found more uniform practice in the selection of smaller catheters and the use of ultrasound guidance for line placement. Due to a recent decline in the frequency of hospitalization for IV therapy, and more importantly, the reduction in the frequency of larger size catheters like 5 French and 6 French catheters, along with the rarity of thrombotic events in our study population, we were underpowered to show significant associations between catheter size and thrombosis. However, in the context of what we know about historical rates of thrombosis in CF in patients with PICCs and the mechanistic plausibility of catheter size affecting blood flow, we believe that our findings are supportive of the current practice of using smaller catheters when able. This is likely to be the largest and most comprehensive study to prospectively evaluate PICC complications in the CF population. And we believe it should yield additional important information about secondary outcomes as we complete our analysis. Finally, I'd like to thank our fabulous group of investigators who contributed to the study with great energy and enthusiasm. We're all grateful to the support from the CF Foundation and the Northern New England Translational Research Grant. And of course, we thank all of our patients who participated in this study.
Thank you so much, Dr. Zuckerman, for your work and for your presentation. I love the physiology with Pessoa's law and everything in there, so that's great. We all have to go back to our basics, right? Yeah. So there were a few questions already about, one was about there's a rare risk of venous thrombosis observed here, but someone felt that they anecdotally see it more often. So she asked if there's any role for rivaroxaban in patients to prevent clots, or will the catheter size alone be enough to reduce the risk of the thromboses?
Well, that's a good question, and I think that that's something that we all deal with. Is if a patient has had a previous problem with clots, we actually looked at that. Did the patients have a previous history of clots? We left it up to the individual center to do their own management, but I should just say anecdotally, if we found that some of our centers had transformed their standard practice to anticoagulating all patients, and they were running into bleeding complications. So I can't make a clear-cut recommendation to anticoagulate anybody with previous problems, fully anticoagulate them rather than just using prophylaxis.
Sure. And there was a question about interventional radiology. If you checked into if they were using the guillotine supplied in the kit, or did they use scissors? In their center, it was Dr. Scanlon, Thomas Scanlon. Mm-hmm. He said there was a prior publication in which they found that it was important.
Well, Tom, I'm not aware. We did not ask that question in our REDCap survey. I should mention though that most of our adult patients did not have their blinds placed in interventional radiology. Most of them were actually placed with a vascular access team in a dedicated suite. So it's actually relatively rare to have them placed in IR these days, in adults at least.
And Dr. Ong from Seattle was saying, was the temporal event analysis you showed also stratified by the type of CF center, such as pediatric versus adult?
Well, I was just showing an example of how we could parse the data. It's actually a very interesting piece of software. We can definitely look at it by pediatric and adult. We've been able to do some of our other analyses based on pediatric and adult, but the particular graph that I showed you didn't separate them by program. It was just by center. So some of the centers had both adult and pediatric patients followed at the same center. Mm-hmm. If any of you are interested in this software, it was developed at the University of Maryland, and just drop something in the chat box and I'll send you contact information for how you can connect with the developer of this software.
Given that bloodstream infections are rare, are we leaving PICs in for a few weeks post-exacerbation in case we need to resume antibiotics in frequent exacerbators, or should the PIC lines still be removed as soon as possible?
Well, I haven't seen that approach used. You mean leaving a PIC in just in case you're going to need antibiotics, just leaving a PIC in without using it? I'm not familiar with that being a common practice.
I'm not either. This was another question, but
I think that it does get to the point of, I guess, for people who are having more frequent exacerbations, mm-hmm. in our practice, we've oftentimes moved to a Metaport, mm-hmm. And I think this raises the question. Maybe in the era of modulator therapy, we should actually be using fewer Metaports, since the PICs do seem to be quite safe to use, especially the smaller bore size, the smaller catheter size.
Dr. Pelusi was asking, could you comment on the pre-post D-dimer and CRP values and whether the D-dimer was useful to identify the few DVTs that you saw?
Yeah, actually, good question. I didn't present that data, but our D-dimers were almost exactly the same pre and post, and they were below the threshold for diagnosis of clot in the population. So it came out as 400 nanograms per mil. We do have some interesting data on CRP that doesn't relate to the incidence of clot. Since the incidence of clot was so low, we really left with looking at secondary outcomes in this study. So we are going to look at predictors of difficult line placement, since we think we have enough events of complicated line placements and also things like pain and local phlebitis. So we're going to be going through our data a little bit more to look at those outcomes. Those would be secondary outcomes.
Okay. Would you say, from the experience you have and what you were talking about from your experience, that Metaport placement is still being considered at a certain number of PICC lines per year, or that the patient would need?
Well, yeah, at our center, for instance, based on the retrospective study done in the Northern New England Consortium, where it looked like there was a higher rate of clots in people who had had more than 5 PICCs. But in that study, we really didn't have historical data. It was only the 5 PICCs during the study period, which was about 10 years long. In this particular study, we went back through the medical record and also interviewed the patients, and we found that many of them had had many previous PICCs before entering the study. So we now find that actually having more than 5 PICCs does not appear to be a risk factor for development of subsequent DVT. So we think that's an important finding.
Definitely. That's very helpful. Well, thank you so much, Dr. Zuckerman. I think we have answered all the questions here, and I really appreciate you being here for our presentation.
Thank you.
Hi, my name is DB Sanders. I'm a pediatric pulmonologist at Riley Hospital and Indiana University in Indianapolis, Indiana. I'd like to thank the workshop organizers for the invitation to speak today. My talk is entitled Site of Intravenous Antimicrobial Treatment of Pulmonary Exacerbations in the STOP2 Study, Home versus Hospital, and I'm giving this talk on behalf of the entire STOP2 study team. My relevant disclosure is that this project was supported by grant funding from the CF Foundation. For background on home IV antibiotics, there are conflicting data on the efficacy of home IV antibiotics. Here are several papers that have been published over the past 25 years, some of which show that home IV antibiotics are better than or worse than IV antibiotics administered in the hospital. Most retrospective analyses have been limited by indication bias, mainly that we tend to not send patients home with IVs that are too sick or who we're concerned are not able to complete the study procedures, as well as differences in other treatment parameters, for example, treatment duration. A more recent registry study that adjusted for indication bias found that recovery of FEV1 after treatment was better for people with CF treated in the hospital than for those treated at home. The STOP2 study was a recently completed randomized study of antibiotic duration for adults with CF who are already receiving IV antibiotics for a pulmonary exacerbation. I'm going to give a brief background on this study and how it allowed us to complete this analysis. Adults with CF were enrolled at visit 1 at the start of IV antibiotic treatment. Their response based on FEV1 improvement as well as improvement in symptoms were assessed between day 7 and day 10 at visit 2. At that point, if they were an early robust responder in both FEV1 and symptoms, they were randomized to a total IV treatment duration of 10 versus 14 days. For those who had not had a robust response in both FEV1 and symptoms, they were randomized to 14 versus 21 days. In all groups, participants were seen back at visit 3, which was 14 days after the end of planned IV antibiotic treatment to assess treatment outcomes. Our conclusions from the STOP2 study was that for early rapid responders, 10 days of IV antibiotics was not inferior to 14 days. And for those with less improvement by days 7 to 10, 21 days was not superior to 14 days. There's some other study design features of STOP2 that I want to mention. The IV antibiotics were selected by the treating clinicians. Participants were asked to continue their chronic therapies, and airway clearance was enhanced as per the usual protocol at the STOP2 study sites. Corticosteroids could be used, though we asked that the decision to use them be made prior to randomization so that the treatment duration did not affect the decision to use corticosteroids. IV antibiotic treatment location in the home versus in the hospital was not dictated, though randomization at days 7 to 10 was stratified by the treatment location. So by balancing the home versus hospital participants at the time of randomization, there's no confounding by treatment duration, as both treatment arms in the ERR group and the NERR group were balanced for IV location. This allows for an assessment of the effect of site of treatment on clinical responses. So our hypothesis for this analysis was that STOP2 participants treated at home would have less mean improvement in lung function compared to those treated in the hospital. For this analysis, we compared the STOP2 outcomes by treatment location. These included change in FEV1 from visit 1 at the start of IV antibiotics to visit 3, 14 days after the completion of IV antibiotics. Change in CRIS, which is a respiratory symptom score. This is the first 8 questions of the CFRSD, as well as change in weight from visit 1 to visit 3, retreatment with IV antibiotics within 28 days, as well as time to the next IV treated pulmonary exacerbation using data from the CF Nation patient registry. Finally, adverse events during the study between visits 1 and visit 3. For the home versus hospital treatment analysis, we use propensity scores to account for indication bias. We use inverse probability treatment weighting and multinomial logistic regression models that adjusted for factors that we thought could be associated with site of treatment and outcomes. Those are listed here. For results, STOP2 enrolled, randomized 982 participants at visit 2. So this is our our cohort for this analysis. Overall, 33% of the participants were treated in the hospital only, 46 both in the hospital as well as at home, and 20% at home only. This was not balanced between the ERR and NERR groups, though it was balanced, again, within the arms, within each group. But the ERR group, the early rapid responders, included 41% of all of the hospital-only participants, so almost half, and only 18% of all of the home-only participants. If we look within ERR and NERR, the ERR group was made up of 48% that were treated in the hospital only, so nearly half, 38% treated both at home and in the hospital, and 13% that were treated at home only. For the NERR group, only 28% were treated in the hospital only. Nearly half were treated at both locations, and 24% of the NERR group were treated at home only. This is a breakdown of the cohort characteristics that were statistically significantly different amongst the 3 groups: home only, home and hospital only. You can pause the video to take a look at which of these that you're interested in. I will note that the hospital-only group tended to be a little bit different than the other 2 groups. So the hospital-only group included a lower proportion female, higher proportion of Hispanic ethnicity, a higher proportion with BMI less than 18 or undernourished, a lower proportion with FEV1% predicted above 50%, lower proportion on highly effective modulator therapy, higher proportion in a no-tier socioeconomic status. What that means is either they were students or they were not working, and there were fewer patients in the hospital-only group that were in the high-tier SES. On average, the hospital-only group tended to be a little bit younger, have a little bit lower FEV1, and a little bit longer distance to their CF center site. So onto our main results. This graph compares the differences in the changes in FEV1% predicted from visit 1 to visit 3 for each of these three groups. And we see that compared to the home-only group, the participants treated in the home and in the hospital, as well as in the hospital only, had a significantly greater improvement in FEV1% predicted from visit 1 to visit 3. The home and hospital group combined had a 2% predicted greater improvement compared to the home-only group, and the hospital-only group had a 3% predicted greater improvement than the home-only group. There was not a statistically significant difference between the hospital-only and the home and hospital group in FEV1 change from visit 1 to visit 3. These were estimated using the inverse probability weighting models, and these p-values are adjusted for the pairwise comparisons. Our other main outcomes were change in weight and change in CRIS scores. Compared to for weight, the hospital-only group had statistically significantly greater increases compared to both the home-only group as well as the home and hospital combined group. There was not a statistically significant difference in the change in weight from visit 1 to visit 3 for the home and hospital group or the home-only group. A similar pattern was seen with the CRIS scores, and there was not a statistically significant difference between the home and hospital group and the home-only group, but there was a greater decrease for the hospital-only group compared to the home-only as well as the hospital and home combined groups. I should mention that the CRIS score is rated on a scale from 0 to 100, with lower scores being better. So these negative scores indicate improvement in symptoms from visit 1 to visit 3. In addition, there was not a statistically significant difference between the time to next IV-treated exacerbation using data from the CF Foundation Patient Registry. The hospital-only group is in black here. The home and hospital is the dark gray, and the home-only group is the light gray. The home-only group was our reference here, but you can see that the hazard ratios were not statistically significantly different. So in conclusion, for adults with CF with IV-treated pulmonary exacerbations, there was benefit to treatment in the hospital compared to treatment only at home. This is true for lung function, respiratory symptoms, as well as weight. These benefits occurred even though participants treated in the hospital only had more severe disease and potentially less access to care, as noted by the lower SES status and longer distance to the care center. Improved outcomes in the hospital may owe to more aggressive care and monitoring that occurs there. And while home IV treatment is likely not going away, the limitations of this treatment should be addressed in order to optimize outcomes for adults with CF who are to be treated at home. I'd like to acknowledge the other STOP2 investigators who participated in this project and analysis, as well as the CF Foundation, Bruce Marshall and JP Clancy, and all of the participants in this STOP2 study, as well as the families, care providers, site investigators, and research coordinators. I also wanted you to be on the lookout for STOP3. We'll have more details coming on this shortly. Thank you.
Thanks so much, Dr. Sanders. This has been really helpful because I know we're always looking at hospitalizations versus home treatment, and which can be better, and also which is better for the patient's life. One person had a question about, based on this study, do you think there should be any change in the practices for pulmonary exacerbations at this point?
Well, I think that's a good question. I mean, I don't think I mentioned in the presentation that this occurred before Trikafta, so things have changed quite a bit already. I think that we do have room to continue to improve our practices, and if there are options for improving home monitoring for the for families that, or for participants, people with CF where it's most beneficial, I think that would be helpful. I think one consideration also is monitoring for labs, and we just heard about PIC complications, and for people who aren't in the hospital, maybe harder they're easier to miss adverse events that would be picked up in the hospital.
Exactly. Dr. Sawicki asked if you captured the frequency of other CF treatments and airway clearance at home versus the hospital.
Yeah, this was designed to be more of a real world study. So we provided just general guidance at the onset of the study to the clinicians, but really we wanted them to mirror their home practice. So outside of the day 7 evaluation and randomization, we really didn't do anything different. So I think part of our hypothesis for differences in outcomes could be the potential differences in airway clearance, adherence, and just time. When you're at home, there's just more things going on. We did track oral antibiotics and inhaled antibiotics and steroids by treatment location, and there wasn't a really substantial difference in those.
Okay. From Dr. Theta Ong, thanks, DB, great talk. Did you see any side effect given some anticipated variation in practice?
Yeah, yes, the answer is yes. We saw quite a bit of variation in practice. We have not dug down into the exact effective site, and these were all performed in adult centers as 18 and above. Some centers, really couldn't administer inpatient IVs. Other centers had different practices. So we try to look for if there was a sort of a cutoff of days in the hospital where you kind of had additional benefit, or maybe where if you kept patients longer but we really didn't see any sort of cutoff like that. There was not much of a variation based on duration spent in the hospital for those participants that were in both locations.
Great. Dr. Kogan said, thanks, Dr. Sanders, for your presentation. Did you take into account whether people were treated at home versus hospital for prior pulmonary exacerbation treatments?
We didn't do that. Our randomization strata included whether they've been treated for 2 or more exacerbations with IV antibiotics in the prior year. In practice, I think that people tend to go to the same location over time. So it was sort of baked into that, but wasn't specifically called out or even tracked. Although now we have paired registry data, we could go back and look at that.
Sure, makes sense. Dr. Rosenstein asked, was there a difference among the groups in the types of antibiotics used or the changes in antibiotics?
Yes, and we're working through that data. That is a pretty complex data, but it's definitely something we are interested in, and we'll hopefully have some information out sooner rather than later.
Okay, sounds great. Did insurance coverage have any impact on the site of therapy for these patients?
Well, we really didn't collect any information about why patients stay in the hospital or went home. So I'm sure in some cases the answer is yes. But yeah, that was one thing we didn't collect. We just the treating clinicians and participants made the decision again, hopefully before the treatment arm was determined. But we don't have the exact reasons why people went home.
Given the relatively large proportion of Hispanic patients, is there a planned post hoc analysis to explore health disparities?
I think that's a good one for us to investigate. And I feel like, we've just gotten so much more information over the past few years, even after the study was planned. So we haven't had it on the docket, but we have quite a long list of post hoc or pre-specified analyses as well as additional analysis we'd like to do. I think that would be a good one to take a look at.
Okay. In this post-modulator area, is there something that your group would like to focus on to make sure, like with STOP3 or anything that would take into account all the new developments?
I mean, I think that this is, still a really relevant question. Especially if we are doing fewer IVs, are we going to be able to keep the practices in place to optimize care, especially going home? So I think that especially and if the modulators are going to help our families recover or patients recover quicker, then home IVs may become even more attractive. So making sure that we're really maximizing the benefit of that would be a good thing to look at. And I think that's something we would definitely like to consider for STOP3.
Awesome. That sounds great. Someone was saying we're sometimes pressured to limit the hospital length of stay. Does the study suggest that patients, I think you kind of alluded to this, should they be in the hospital for a minimal amount of time? Yeah,
I think that was, sort of a very late, post hoc analysis within this analysis. I don't know that the data for that is so strong to affect, insurance, decisions. Well, I would hope that it wouldn't affect insurance decisions or hospital decisions to push patients out. Again, it is, this is a population average result, and it provides some guidance for us, but I don't think, I'd be interested to see how it changes care, but I think it'd be hard to have hospitals look at this and say, now we need to change, what you're restricted to based on these results. But hopefully will be helping us make, as clinicians, better judgments with families about what's best for our patients.
Right. And talking about like the perspective of the patients in terms of their desire for hospital versus home care, is there a way to maybe include community voice or other patient groups to see what largely is desired by the patients, or is it more of an individualized decision?
Yeah, thanks. No, I think that's a good point. We actually have had involvement with community voice kind of all along. And one of the things that we asked for was some feedback on this study. And I think, the main benefit is now we have some data to help weigh this information, and the results we presented were adjusted for other confounders. So I think, you now can look within the individual and see which of those, other factors are in play and how much of a benefit there might be. So I think that's kind of the main. We just really didn't have any good. We were restricted in our data to single center studies and inability to adjust for indication bias. And now we have some more data to inform those conversations.
Yeah, that's wonderful. Thank you so much. And I think we've reached the time for this session, but we have 5 minutes left in our overall session. So I didn't know if there were any other questions out there. I think I haven't seen any on the chat, but I can give it 2 more minutes. If you have any final comments, Dr. Sanders, since you're up last. Sure.
I think that we just, it's good that we were able to answer some of these questions. I think a lot of these questions are still going to be pertinent in the modulator era. There's a paper that showed that for patients in the hospital, it seemed that recovery of FEV1 on ivacaftor wasn't improved prior to ivacaftor. So I think that hopefully these IV courses are fewer and far between, but it doesn't mean that our outcomes for our patients who do need IVs are necessarily improved. So I think that going forward, this is still going to be really important.
I agree. And also it's the patients who don't have access to modulators, who may be still admitted or need these frequent interventions, that it's going to be important until they get up to speed with the modulators that are available or other treatments.
Exactly. Yeah.
Yeah. Great. Well, I hope you all have enjoyed our discussions today. I wanted to thank all our presenters, Drs. Ramos and Paluski, Drs. Gubacek, Jane, Zuckerman, and Dr. Sanders. Thank you so much for all of your discussions today and making our pulmonary potpourri so fruitful. And we hope you have a great rest of your NACFC.